Okay, so the conduction cycle starts in the SA node and is where the impulse starts. It then spreads across the atria and causes the depolarization or the contraction of the atria at the same time. This is seen on the ECG as a P wave. So the P wave is always associated with the atria. The repolarization of the atria isn't seen on the ECG. It's covered up by the QRS complex, but the repolarization can be thought of as the re-empowering or re-amping up of the atria or ventricles. So the impulse then travels from the atria down through the bundle of His, which is found in the septum. It goes to the Purkinje fibers, which are found on both the left and right sides of the ventricles, and this allows the ventricles to contract or depolarize and is seen on the ECG as the QRS complex. So the QRS complex is always associated with the ventricles. It is then seen on the ECG as a T wave, where the repolarization happens of the ventricles. So again, starts in the SA node in the atria, causes the atria to contract, which is seen as the P wave, travels down through the bundle of His to the Purkinje fibers on the left and right sides of the ventricles, which causes the ventricles to contract, seen as a QRS complex, and then the repolarization of the ventricles is seen as a T wave. So if there is an issue with the P waves, then it is associated with the atria. If there is an issue with the QRS complex, it's associated with the ventricles. And then the T wave, again, is also associated with the ventricles, but most arrhythmias are either with P waves and QRS waves. So for the interpretation of arrhythmias, the first step is always to see if there is a P wave for every QRS complex and a QRS complex for every P wave. So we'll start with the P waves. Is there a P wave for every QRS complex? Meaning, is there a P wave followed by a QRS complex? If the answer is yes, then there is no missing P wave. You have a P, a QRS complex, and there is a normal sinus rhythm. If no, you're missing P waves and you just have QRS complexes, then there is a bigger issue, and we'll go into those kind of arrhythmias in a moment. But if there are P waves that happen alone, not followed by a QRS complex, then there is some type of AV block or atrioventricular block. So in that name, it kind of tells you what's going on. The atria are contracting, and then there is a block from the atria to the ventricles. So as we just went through in the previous slide, there is the conduction that happens through the atria, and then they spread down through the ventricles. So if there's a P wave, your atria contracted. If there's no QRS complex, then the ventricles did not contract. So the next slide will go into heart blocks with first and second degree heart block. So first degree AV block, there is a P wave and there is a QRS complex, but there is a delay between the P wave and the QRS complex. So there is a little poem you can remember that is, if the R is far from the P, it must be first degree. So there's a P wave, and then there is a delay between the R QRS complex. So there's a block happening where the conduction is going from the atria and somehow is being delayed to get to that ventricle to cause that contraction. For a second degree AV block, there is a couple different types. We won't worry about them. The big thing is that there is a P wave and then a really long delay, another P wave, and a QRS complex. So basically there's a P wave that is happening all by itself, not followed by the ventricles contracting. So if we look at the first strip here, there's a P wave, a normal delay, a QRS complex, and a T wave. Then there's a P wave, a bit longer of a degree of a block there between the QRS and the P wave, and then a T wave. And then here again, there's a P wave, a delay, a QRS complex, a T wave. But there are still a P, a QRS, and a T wave. And then the next one here, there is a P wave, and then a long delay, no QRS complex, and another P wave. So this is second degree AV block. There is a P wave not followed by a QRS complex. So with the second degree AV block, there are a couple different reasons that would happen. Sometimes the one I see more often than not is associated with a bradyarrhythmia, meaning a slower heart rate, usually associated with dexmedetomidine administration. And if this is the reasoning and the heart rate's really slow and there's a QRS complex a P wave with no QRS complex, and you have second degree block, and you're seeing it intermittently, then it could be related to the dexmedetomidine, and you can prove this by the administration of atropine, so an atropine test, and if that fixes it, then it was associated with the bradyarrhythmia. A lot of the times, the second degree heart block is something I will tell a veterinarian about, and if it's not happening all the time, they won't get overly excited about it, especially if we have given them dexmedetomidine. So for third degree heart block, though, this is associated with a complete block between the atria and the ventricles, where the atria are firing at random and so are the ventricles. So there's no association and there's no proper conduction of the heart cycle, meaning there isn't a proper output of blood. So this is a problem and is something that can be really concerning. And if it continues, then they usually need a pacemaker. So third degree heart block is when there are multiple P waves and no QRS complexes for every P wave. So yes, there is a P wave, but there is not a QRS complex associated. And basically what is happening here is that the atria are firing and causing those P waves independently from the ventricles contracting. So there is no relationship between the QRS and the P waves. The poem that you can remember here is, if P and QRS beat independently, then it must be a complete third degree. You can really remember this because there'll be more than one or two P waves and then a QRS complex. So if there's one P wave followed by no QRS complex and then a normal P QRS complex, that is second degree. If there are random P waves and random QRS complexes, then it is third degree. So if you get out your basic ECG interpretation document from Megan Brashear, this is an excerpt of the VPC section. So VPCs are ventricular premature contractions, which basically the left ventricle is contracting prematurely, leading to those large T waves that are deflected or in the opposite direction. So depending on how many you have in a row and what the heart rate is, it can either be just a few of them where you're watching this and there is no treatment needed. If there are runs of them, and then it will convert back into a normal sinus rhythm, as seen on this ECG. If you look at the very first one, there's a VPC and then a run of regular normal sinus rhythm. There's a P, a QRS, a P, a QRS, and then it runs into more VPCs. So if there are ongoing VPCs with no converting to a normal sinus rhythm, depending on what the heart rate is, it is either VTach or ventricular tachycardia, or AIVR, which is accelerated idioventricular rhythm. So that is defined by a heart rate that is between 70 and 160. So it does not go above 160. It's accelerated idioventricular rhythm. If it is above 160, and most of us say 180, so in the notes I have 180. If you look in the textbook, VTach or ventricular tachycardia is defined at a heart rate above 160. We don't treat VTach unless it's above 180. So if it is between 160 and 180, then it is ventricular tachycardia, and that is the difference between AIVR and VTach. So this is just a slide reiterating what I said in the last slide concerning tachyarrhythmias. So tachyarrhythmias are arrhythmias associated with a heart rate of over 180. So we'll also say 160, but we don't treat until over 180. So that is the important number. So VTach, ventricular tachycardia, is a run of 3 or more VPCs in a row at a heart rate above 180. That can quickly lead to arrest if it's not treated, especially if there are runs of this. So more than 3, let's say there's no converting to normal sinus rhythm and you don't treat with lidocaine, they can arrest and die. If it's pulseless, so they can have VTach with pulse deficits, but there's still a pulse. If they have pulseless VTach, so no pulse that is palpable, then this is a shockable rhythm, and this is part of your CPR training. So there are 2 that we discuss. One is pulseless VTach, that is a shockable rhythm. The other is ventricular fibrillation. So we'll get into that after, but right now we're just talking about tachyarrhythmias. As I said before, AIVR are strings of VPCs, but it's at a slower heart rate of less than 160. Again, this is taken from the basic ECG interpretation. Just goes on to show you what VTach looks like. So you can see in the picture here, there are a break at the top where there's one normal NSR seen at the top, and then the second and third lines, it's just a run of VPCs. You can see here on the screen the heart rate is 197. So this is full-blown ventricular tachycardia, and this patient needs to be treated with lidocaine or they could arrest. So this is what VTach looks like. So before we get into any more of the arrhythmias, I just thought we should discuss what is taken from the overview section of the notes at the beginning of the module. So it says there that you should be able to discuss sinus bradycardia, sinus tachycardia, and sinus arrhythmia. So sinus bradycardia means that there is a normal sinus rhythm, but the heart rate is slower than it should be. Sinus tachycardia, same thing, normal sinus rhythm, but there is a tachycardia or a faster heart rate than normal. Sinus arrhythmia is a bit different. So sinus bradycardia. If we look at the notes from Module 1, Topic 4, there is a table there that lists the normal heart rates for dogs and cats. So dogs technically are normal heart rates are 60 to 180, and this is quite a variance because there is a variance in the size of dogs, and basically the smaller the animal, the faster the heart rate, the larger the animal, the slower the heart rate, as seen in horses, say. So Technically, anything that is slower than 60 beats per minute would be a bradycardia. Anything faster than 180 would be a tachycardia. It is sinus tachycardia and not an arrhythmia or a VTach because there is a sinus rhythm. So sinus bradycardia, sinus tachycardia, normal rhythm, normal sinus rhythm, just a slower or faster rate. So ventricular fibrillation, or VFib, is another one of the fatal arrhythmias that is shockable and is discussed in your CPR. So VFib and pulseless VTach are two of the shockable rhythms that require defibrillation in order to convert this back to a normal sinus rhythm. If you're looking at your animal and they look completely normal, they're standing, they look like there's nothing wrong, then this could be some kind of interference or your ECG isn't attached properly. So then you would troubleshoot that, make sure everything is attached properly, and reevaluate. If you see this and your animal looks dead, then it's probably ventricular fibrillation. I will say that this isn't something that you see often, either is pulseless, VTach. There are a handful of times I've actually seen a defibrillator used at all, but these are rhythms that you need to be aware of and be able to identify quickly, because if they are true, then that animal needs to be defibrillated immediately or they may not be resuscitated. So atrial fibrillation looks like this ECG tracing here, where there looks like there's normal QRS complexes and then there's those squiggly lines in between them. So this can be confused or misinterpreted as interference with your ECG. And the way you can troubleshoot this is if you listen to your patient's heart, it will sound like tennis shoes in a dryer, like this states here. And it really does sound like that. It sounds like flipping and flopping. It doesn't have a normal sound, or you can't count the heart rate a lot of the times. So if you hear this awful sounding heart and you see this strip, then it is atrial fibrillation, and it is not something that is interfering with your ECG tracing. If you read from your textbook, it says here that this is a result of the rapid and uncoordinated series of atrial depolarizations. So that means that the atria are just firing quickly and without any kind of coordination at all, and that's what's resulting in this strange looking squiggly lines, which if you look at, kind of does look like a whole bunch of P waves jumbling together, which would kind of make sense because we know the P waves come from the atrial depolarization. So if you see this, check your patient's heart, hear what it sounds like, and if it sounds like tennis shoes in a dryer, then you do have atrial fibrillation.